All right, so blood pressure regulation has both short-term and long-term possibilities. So if you think about in the short term, rising blood pressure, say a fight or flight reaction, stretches the arterial walls, which means with increasing pressure, with increasing force, those walls aren't as close to each other as they used to. That stimulates pressure receptors, otherwise known as baroreceptors, like a barometer, right, measuring atmospheric pressure. So they get further away from each other, which increases them sending signals to the brain, and this is from the carotid sinus, from the aortic arch, and in other large arteries. Those increased impulses to the brain go by cranial nerves 9 and cranial nerves 10, which come off the medulla oblongata in the brainstem. And if you remember, cranial nerve 10 is the chief parasympathetic nerve from the body. So, if you're stimulating the vagus nerve, the chief parasympathetic nerve in the body, that's going to increase parasympathetic activity and decrease sympathetic activity. That's going to reduce heart rate, and it's also going to increase arterial diameter, vasodilation, that's smooth muscle relaxation, which should hopefully result in lowered blood pressure. So you think about this as sort of a Cushing's reflex in patients who have high blood pressure and intracranial pressure. So as their blood pressure goes up, they get a parasympathetic reaction, their heart rate goes down, which is sort of a catastrophic sign in people in neuro ICU. Elevated blood pressure, decreased pulse. Well, that decreased pulse is trying to, in one hand, decrease their overall blood pressure. So the short-term regulation of lowered blood pressure is you have the blood pressure actually falls. So say an acute bleed or a vasovagal reaction or a neurogenic shock. Remember those baroreceptors, which increased their activity when they were separated apart because of the increased pressure in the example before? Well, now those blood vessels are collapsing. Right, falling blood pressure. So those baroreceptors are inhibited. They decrease those impulses to the brain. That decreases parasympathetic innervation and results in increased sympathetic innervation. So what do you get? Increased sympathetic, increased fight or flight. You get that increased heart rate, which is the tachycardia. That's a very early sign of hypovolemia, an early sign of inadequate perfusion. You get an increased strength of cardiac contraction, so that bounding pulse. Vasoconstriction, and you get an adrenal response with epinephrine and norepinephrine. So those are great in the short term. If we take a look at longer term blood pressure regulation, we really have to look at the renin-angiotensin-aldosterone system. So most of you are familiar with this from early physio, or you're huge amounts of your patients are on ACE inhibitors and captopril and things of that nature. So let's just go over it. It sounds a little bit more complicated than it actually is, and if we take it apart piece by piece, it's really not that bad. So the first thing to remember is that here's the kidney. In the kidney, it has that macula densa, which are those specialized receptor cells at the juxtaglomerular apparatus. So in this whole RAAS cycle is stimulated by three parts. Number one is sympathetic stimulation, fight or flight. Number two is hypotension, which is reduced blood flow to the kidney, at least as the kidney senses it. And number three is decreased sodium delivery. Again, we have receptors in the kidney which are maintaining what the levels of sodium are. So if any of these three situations, sympathetic stimulation, hypotension, or decreased sodium delivery, if that's either of those three are sensed by the kidney is going to secrete renin, or renin. I go with renin. It is what it is. Renin's going to combine up with angiotensinogen. Angiotensinogen's always present. Okay, it's just waiting for renin to be released, so it combined with it. All right. So in the presence of renin, angiotensinogen gets converted to angiotensin 1. Angiotensin 1 really doesn't have that many adverse effects that we're aware of right now. So if angiotensin 1 is circulating in the bloodstream, nobody's really that concerned. What happens is angiotensin 1 gets converted by the angiotensin converting enzyme, ACE, to angiotensin 2. And what we understand right now is that angiotensin 2 has a load of effects. What you need to understand is that the effects of angiotensin 2 are perfect if you're dying. Okay, so if you need a fight or flight response, if you're running away from a pterodactyl, or if you're bleeding or somehow have loss of perfusion, or if you need increased sodium, required electrolyte, then angiotensin 2 is exactly what you want. That's perfect. There's only one problem, is that blood pressure regulation, especially in the United States and the Western world today, these things have gotten out of control. So what does angiotensin II do? Well, let's start over from clockwork. Angiotensin II stimulates the adrenal cortex to secrete aldosterone or aldosterone, depending on where you were born. Aldosterone is going to cause sodium retention. It's going to pull back sodium from the kidneys. Where sodium goes, water follows. That's going to increase the amount of fluid in the cardiovascular system. So that should hopefully increase pressure, right? If you have the same sized tube or the same sized piping and you increase the amount of fluid, then the amount of pressure should go up. So we stimulate the adrenal cortex to secrete aldosterone. Angiotensin II is also going to stimulate the pituitary gland to secrete the antidiuretic hormone. Antidiuretic hormone is going to act more specifically on water, causing more water to be reabsorbed in the kidney tubules, in the collecting duct, and water is going to be pulled back. That's also going to increase the amount of fluid. You have the same piping, an increased amount of fluid, that should hopefully increase the pressure. Angiotensin II is also going to stimulate the thirst reflex, which should cause you to drink more, right? In the GI tract, the water is going to be absorbed more freely, again increasing the fluid. Angiotensin II is also a potent systemic vasoconstrictor. So that's going to activate on the smooth muscle throughout the blood vessels, reduce the size of the piping, again trying to increase the pressure. Angiotensin II causes cardiac and vascular hypertrophy. Again, this is over the long term. You're not going to go through instantaneous cardiac hypertrophy, but over the longer haul, we see this as a result. So angiotensin II has all of these effects in trying to stimulate or trying to counterbalance these three potential initiators. Okay, so the reabsorption of sodium from aldosterone would take care of the decreased sodium delivery. All of these other effects, increasing thirst, increased ADH, increased aldosterone, cardiac hypertrophy, systemic vasoconstriction, and those would try and balance out hypotension. Okay, and the other effects are trying to just be a reflexive action from sympathetic stimulation, fight or flight. All right. And in pharmacology, what the ACE inhibitors do are they take out ACE. ACE is the conversion from A1 to A2 typically happens in the epithelial cells of the lungs. So that's really why in ACE inhibitors, very commonly, the most common side effect is going to be a dry, hacking cough. So with ACE inhibitors, if they take out ACE, then you can't convert A1 to A2. So all you have is a whole bunch of circulating A1. In the last 5 years or so, they have found that there is at least a small amount of angiotensin I that gets converted to A2 without going through ACE. So what you've come up with is ARBs, which is angiotensin receptor blockers. And that also is a good effect or a good choice for patients who are complaining too much of the cough. If that gets in the way too much, then you can switch them over from ACE to ARB. And it looks like the data says that ACE has some beneficial effects for diabetics in improving kidney response, improving renal protection. So there's some interesting data. So that's renin-angiotensin-aldosterone. Angiotensin II, again, promotes cardiac hypertrophy, stimulates thirst, the vasoconstrictor, promotes that ADH release or vasopressin from the posterior pituitary, stimulates the adrenal cortex to secrete aldosterone. All right, so a diuretic makes you urinate. So what does an anti-diuretic do? There's a lot of students just get lost, and I ask them, if you inhibit ADH or if you cause ADH to be secreted more, what happens? So if a diuretic makes you urinate, the anti-diuretic hormone is going to reduce the amount of urination, specifically reducing the amount of fluid being lost. And aldosterone is going to act to increase reabsorption of sodium from the distal convoluted tubules and the connecting ducts. And again, where sodium goes, water follows. All right, this is what happens in the absence of ADH. Right, you have a large volume of dilute urine. In the presence of ADH, you have a small volume of very concentrated urine, but you've reabsorbed all the water back out. All right, so you should be comfortable in explaining this process. And if we move over now, we'll actually discuss, the disease hypertension. So, if we look at recommendations which first came out from the Joint National Committee, Prevention, Detection, Evaluation, Treatment of High Blood Pressure, usually with shorthand JNC7, the classification of blood pressure for adults changed, and this is where we first saw the definitions of pre-hypertension, which usually went down to what we'd considered normal for many years, right? 124 over 88, and we'd say, okay, that's normal, or 128 over 82, and we'd say that's normal. Well, recently that's been reclassified as pre-hypertension. What they're finding when you do the long-term data is that even quote-unquote healthy adults who have their blood pressure within these ranges, if you look at them over the long term, as they get older, they start to develop more prevalent hypertension. Okay? And of course, this is based on the average of 2 or more readings taken at each of 2 or more visits after the initial screening. Right? So we look at the diagnosis of high blood pressure no earlier than 3 consecutive visits, which usually takes about 6 weeks. Okay? Normal blood pressure with respect to cardiovascular risk is less than 120 over 80. So this is really where we're going now at trying to keep it lower than 120 over 80. If you look at hypertension, hypertension's classified into 2 ways. Number 1 is essential hypertension, also known as primary, and number 2 is secondary hypertension. So primary hypertension has no clearly identifiable or correctable cause, and it is the majority of the cases of high blood pressure you see. It's the high blood pressure that uses the thiazide diuretics and the beta blockers and the ARBs and etc., etc., etc. It's most of your high blood pressure patients. The secondary hypertension are the disorders where if you go in and correct them, the hypertension will go away. So for instance, hyperaldosteronism, pheochromocytoma, renal artery stenosis, a variety of other causes where if you go in and the patient has renal artery stenosis, which causes the whole renin-angiotensin-aldosterone cycle, and you go in and you revascularize the renal artery, the kidney now gets its own blood supply, it doesn't think you're dying, and it stops secreting all the renin, and life is good. So the hypertension should go away shortly thereafter. You know, most of your patients who have essential hypertension, you give them thiazide diuretics, you give them the beta blockers, give them the whole medical handbook there, the whole pharmacopoeia, and if you take them off the drugs, their blood pressure is going to spike. So in secondary hypertension, if you treat the underlying cause, the hypertension goes away. Essential or primary hypertension, no really clearly identifiable or correctable cause. We have great ideas about the pathology, about hypertension. We have ideas about sodium involvement and pressure overload and etc., but no really cellular process by which to correct. So if we take a look at hypertension, a couple of issues regarding, so we can have hypertension due to increased cardiac output, so things like hypervolemia, and that can happen from renal artery stenosis or renal disease, hyperaldosteronism, hypersecretion of the antidiuretic hormone, coarctation of the aorta, preeclampsia, pheochromocytoma, which is an increased levels of catecholamines, epinephrine, norepinephrine. We can also have systemic vascular resistance, which is the most commonly when we're talking about idiopathic, primary, or essential. Sympathetic stimulation, which is going to cause those smooth blood vessels to constrict. Atherosclerosis, renal artery disease, again also pheochromocytoma, thyroid dysfunction, diabetes, and cerebral ischemia. So this is going to end part 2, and we're going to come back for part 3.